And I'd like to now hand over to Dr. Paddy Moore and move into the clinical considerations. And we have about 10 minutes, but you know, depending how the discussion go. Paddy, would you like to talk to us about the extending GPs training and skills toward curettage practice? Now you're muted. Let me see.
Sorry, I'm slow off the mark.
Sorry, guys. We're either talking too much or not at all. Really, this was just to give everybody a bit of a for your information and just a bit of an update on what we're doing. So this, as part of the, sorry, did somebody speak? No. As part of our decentralization service to regional and Victoria, when we've been going around and talking about medical abortion, one of the things that comes up quite frequently from the practices and particularly from the GPs is a concern that what can they offer women in whom there's been a failed medical abortion, so someone with an ongoing pregnancy, and how do they arrange care for that woman, and feeling really that they've compromised her somehow, you know, so a sense that they can't follow through her care, and we all know that that can be really tricky, particularly in regional areas, trying to get a curette, a surgical abortion at that gestation, which would be somewhere after 9 weeks, and or being able to provide curettes themselves for those patients that have got some bleeding afterwards in association with retained products. So it's those two things that people have become quite concerned about, and I've been approached by quite a number of GPs wanting to upskill, and they have sometimes approached people in their hi Louise, they've sometimes approached people in their locale, so gone to the secondary hospitals near them, but they haven't had a very good reception necessarily. So the group of GPs that we can offer some training to are in particular the group that have already got their diploma, their advanced diploma in ONG, and we have trained 2 GPs to increase their gestational age and to feel a little bit more confident with doing curettes. Both of them were already doing curettes, so that's a GP up towards Castlemaine, Mark Perugia, and the other one is Sam, who is in Gippsland. And we've then been approached by a 3rd GP who isn't an advanced diplomat, but who wants to set up a medical abortion service and then be able to be the GP who does the curette if the woman has got retained products and is bleeding heavily, being aware that that is the minority of the patients that would need that, but just to really facilitate that woman's care. And so far we have trained 3, and we have limited ability to offer this far and wide, but I suspect it's not going to be something that overwhelms us in terms of the number of people that ask for our help. So what we've suggested at the moment is that people can contact Kath or I, and Kath is much more email available than me, so when we go around we do put out Kath's contact as being the primary contact. The steps that people have to take are they have to contact us, talk to us about what they're interested in doing, and they have to then become credentialed at our hospital, because this is essentially a training service that we're providing. For rural and remote GPs, there is a rural and remote training scheme, and all of these GPs that have come to us have been able to be paid by that scheme for loss of earnings for the day that they come. And so it's, I think each of them has done 4 or 5 sessions with us before they felt confident, and that session involved a couple of mornings in the clinic and then 4 to 5 afternoons in a list, where we give them a fairly busy and varied list. So we've been really delighted with A, their commitment, and B, how it's gone, and the feedback that they have been giving us. So I wanted to let people know that we're open to that kind of model. We don't think that we need to provide this for secondary metropolitan hospitals, because they should all be able to provide the training themselves, but it's really for the regional hospitals. And so I invite people to have a chat about that now, what they think about that. Is that something that people would ever feel that they would want to do? Are we on the right wavelength, or are we approaching this wrongly? Any suggestions or comments?
I would like to say something, Paddy.
Hi, Purnima.
Hi, Paddy. How are you?
Good.
It's actually a good. It's a good way, but we work in Bendigo here, and the hospital, Bendigo Health, because as you know, I have done Branscog Advanced, and I used to work at Bendigo Health.
Yeah, yeah.
And we do also have a private hospital, St. John of God, which is, I don't know how they take it in terms of medical terminations. And doing, myself going and doing curettage at Bendigo Health, it is a very, very rare scenario, because they have their own staff, they have their own registrars. I haven't never, in terms of Castleman, which is not far away, I never inquired about going and doing any procedures there, which I may need in future. But in this setting, I'm not sure how is that going to be helpful. Is it just the curettage we're talking about for written products, or also for any surgical terminations? Or
it depends on people's needs. So just listening to you, it sounds like you don't have a need for that, because there is a responsive service. Excuse me, are the people who are in the garden up there drinking wine as well as being outside getting vitamin D? Outrageous. Welcome to regional and remote Australia. Yeah. So Purnima, just listening to you, seriously, it doesn't sound like you need to provide that service. So what I'm thinking about is just explaining to you that Mark Farrugia and Sam and Joel, the three that we have trained already, have a service gap where they are. Either there isn't someone available to do the follow-up curettes, or they're not willing to do it, or they are already providing an abortion service and want to be able to extend their gestational age. So it's certainly not us saying to you, you should all be doing it. It's just if people have a need.
Yeah.
And initially in Bendigo, there was a bit of pushback whenever anyone went to the emergency department. But what are your experiences at the moment? Is it all going quite smoothly with the staff at Bendigo?
Yes.
Yeah, so that's great to hear, because Louise Holland, who's here, would attest to when it wasn't great, when there was a bit of pushback. And so there's been a huge amount of work done there, so that's great. So yeah, not suggesting at all, Purnima, that everybody has to train this way. It was just if people want to do it.
Understand. Okay, thank you.
So for example, just to talk about it a little bit more with Joel, who's in Wonthaggi, he is very keen to provide and has started to provide medical abortion, but he works in a practice where the practice leads are conscientious objectors, and they have said that they are okay with him doing whatever he wants to do because they respect his own integrity and ethics, but he's not to do it on their property. And so he is now running his clinic in the emergency department at the local hospital. And so therefore, he hasn't actually got a gynecologist as a backup there, but he's got gynecologists at, what's the next place? Warrigal. Yeah, Warrigal, who'll back him up if he has a problem. So that's just to give you an idea of that model. So he's bridging the gap between Warrigal and where he lives by providing the service himself. And interestingly, he's found that like after 3 sessions that his learning curve was really steep, but he's now feeling a lot more confident.
Great. Thanks, Paddy. Any other questions or comments to Paddy or around that topic to anyone else that you have heard speaking? Not specifically, no? All right. I mean, we can intertwine this discussion into whatever comes up in a more organic way. But if there are no further comments, then can I then hand over to Dr. Ling Li from Gateway Health? Ling Li, you're going to talk to us about your perspectives from rural GPs and GP registrars on providing abortion care and upskilling. So, yes.
Yes.
Is that the correct focus?
Yes, a bit different than what my expectation, but I can certainly talk about that. So hello everyone, it's my first time to join this meeting, and my name is Ling. I'm currently a GP registrar in Gateway Health in Wodonga. I started my extended skill training in Gateway Health from February this year, and this extended skill training position is relatively new. It was created by Dr. Orr in late last year. And but this new position is actually based on our well-developed Clinical 35 and Women's Hub. And from the past 8 months, I realized that we have a big variety of different reasons for presentations, and we have a large amount of patient population, including quite some non-mainstream stories there. And my current work, including general patient care, just the same as a normal GP. And also I spend about 50% of my time on the management of STI, women's health, urinary genital health problem of guys, and pregnancy shared care, termination of pregnancy. And our own Mirena clinic will open in about 2 weeks' time. And in our clinic, we also see, or I got the training for PrEP, PEP, HIV management, also transgender care. And abortion, medical abortion, or surgical, or initial workup for surgical termination is an important part of our service. Before I started my training here, I had no experience in this area at all. And but from as a registrar, I feel I was well supported by Dr. Orr and also by our very experienced nursing staff. And this medical abortion, this clinic is pretty much, is actually nurse lead. And as a doctor, I think I learned more from our nursing staff. And the other thing is, compared to the hospital training position, I believe before this training position, all the sexual health training position in my training area, they are in Melbourne, they are hospital based, not GP based. So in my training area, this is the first GP clinic based sexual health training position. I think it's much better than the hospital ones, because you got the chance to actually work in a setting that you will work in the future, and all the protocols and the workflow are just GP friendly. And from the past 8 months, I got a lot of first-hand knowledge. They can be quite different from what the textbook taught me in many years ago. And I think the other most important thing is you gain your confidence in managing those conditions. It can be quite sensitive to a GP who doesn't have much experience to talk about the termination. But I think whether or not we will, or whether or not I will continue on in this area, most likely yes. I think this 1 year experience is quite important for me. And my current plan for next year will be relevant to this area. Any questions or any other thing anyone want me to talk about?
Comment. Just a comment. That is just a phenomenal program that's been put together. Did you have to initiate that as request, that was the sort of thing you were wanting, or was that there and you just found it, you know?
Oh, I became interested in sexual health after a mandatory course from my training provider. But at that time, as I mentioned, the only training position was in Melbourne, and it was hospital based. But look, we have that clinical 35 in town, and it was such a success. And it meets all the criteria what an extended skill position needs. So I got in contact with Dr. Orr, and we discussed about this. Within a week, she is super efficient. She created.
Oh yeah, she is.
And I believe this is probably the first GP registrar training position in sexual health, at least in Victoria, probably in Australia.
I wonder, are you thinking of presenting this or writing about your experience for any of the GP publications or conferences? Because it's really great. It's just so great.
You mean the clinical 35 or the GP training position in clinical?
Yeah, the
35?
GP training position, yeah.
Oh, I haven't thought about that. I just thought I was lucky enough. I was extremely lucky because this new position is just created by Dr. Orr, like clinical 35. And I think it's better than all the other positions because it's based in a GP clinic.
Well, at the very least, maybe this group, when we think about our next conference, showcase this model that Catherine and her team have worked on and that you've been the first recipient of, you know, that we really showcase it because it's a great model. And one of the strengths of this network is that we just share resources and ideas and then other people pick up on it. So it could be really useful, couldn't it?
Yeah, and then with the newsletter, one regular section will be getting to know a regional practitioner. So that would be a good opportunity to profile the training program as well as your role.
Yes, that's a good
idea. On the
idea.
list, Kylie.
So you wouldn't mind if Kylie approached you to write a couple of paragraphs or something to just profile it?
No problem.
Fantastic. Thank you so much.
Anything else anyone want to know?
Yes, sorry, I have a question, Link. So we are expecting the registrars in a similar position as you had, like extended skills training program at Bendigo Community Health from February next year. So I just, because this is also very new for us, our clinic is very well set up in terms of sexual and reproductive health. We also produce contraceptive and STI screenings and medical termination of pregnancies. But what was your learning requirements? Did you need to do any exams after you finished the extended skills program? What else is involved?
I think it's mainly experience based. You have enough exposure to certain topic. You have enough experience. You learn while you're practicing. And also also during my training, I got opportunity to attend different courses, including Mirena insertion, including HIV care, like a S100 prescriber course, and also PrEP and PEP courses. So I did do some exams to have the certificate for like becoming a S100 prescriber.
Okay, sure.
But because I believe because I was the first one and the clinic is very well developed, everything is in protocol, and but the training itself was like we worked it out as we are moving forward.
And who was your training provider? Which regional training providers you come?
CCC, Murray Coast.
Murray Coast. And Kathy Kerr was your supervisor?
Who?
Who was your supervisor?
Dr. Orr, Dr. Catherine Orr.
Dr. Catherine Orr. Okay, yeah.
Great, thank you,
Absolutely.
Lily. Any other comments, questions, thoughts?
So I was just asking Purnima, is that the kind of model they're looking at developing for next year? Was that what she was saying?
Yes, yes, Dr. Paddy. So we have got two registrars who are coming in for an extended skills program to community health. So it looks like it's quite similar to what Ling was. That's what they're coming there for exposure and learning, so that they can learn the things and then they can utilize them in future in their careers.
I think
Great.
one is passionate in this area or have genuine interest, they will be able to find out a topic that they want to be more advanced in. Like if they're more interested in HIV care, they're more interested in transgender care.
Yes.
That's great. Maybe something we mentioned at the hubs meeting. But, you know, these are two hubs and they're really developing the GP training.
I don't realise they're speaking.
Hi everyone, this is Louise.
Yes, Louise.
That was a fantastic overview, and I think that Bendigo Community Health Services would be absolutely delighted if our GP registrars could do all that. I really think the purpose of our extended skills is around women's health and sexual and reproductive health, with the emphasis on IUD training and IUD insertion and MTOPS. We have an infectious diseases service here at Bendigo Health where people living with HIV are quite easily managed through that. Peter Strange, our men's health nurse practitioner, prescribes PrEP. So it would only really be if the GP registrars were absolutely very interested in HIV care, would they probably do that. But our main priority is around women's health and sexual and reproductive health at the moment. Thanks.
Great, thanks, Louise, for that comment. That's wonderful. Anyone else would like to comment on anything you've heard so far? Is there anything else before we move to the next agenda item? No? All right, feel free to come back if you have questions and thoughts, also of course coming afterwards, so no problem at all. Let's move now into the next topic. So Dr. Purnima, I'd like to you take the floor now, the virtual floor, and I have here written down that you would like to talk about the issues relating to adolescent women accessing MTOP. So yes, please take the time to talk what your experience in this area is.
Hello everyone again. I wanted to talk about this topic, especially the teenage medical termination of pregnancies, because we are doing. I'm working in Bendigo Community Health for the last 2 years. And medical termination of pregnancy I started doing at community health because there is not much of exposure at the hospital system. Sometimes I come across some of the challenges in managing teenage patients. So I just wanted to talk about this and also to ask about your views or your experiences, whether you have come across similar kind of a patient or situation and how you have dealt with this situation. So in the Louis has also we have done a bit of audit, and when we look back, we have done 150 medical termination of pregnancies, out of which there were 6 teenage medical terminations. So one of the things I find it harder is consenting. We know about Gillick's competency of consent. Some are quite straightforward, so you can say, okay, she understands the procedure, she understands the side effects, she can reproduce the information given, so that's straightforward, fine, she can have a medical termination of pregnancy. The other one I find it very hard is the patients who have mental health conditions, because there was a girl, 15 years old, who came in requesting a medical termination of pregnancy. She was very not very decisive, like she didn't make any decision whether she really wanted a medical termination or not. For me, it was very difficult to understand whether she really, it was an unwanted pregnancy, she wanted a termination, or is she because she was worried because of her mental health, she's not ready to have a baby. So then we involved the nurses who had seen her before, and then I even needed to call the psychiatrist who she was under to make sure she's stable, so that I can go ahead with medical termination. So I thought that was a little bit challenging, whether, I don't know whether medico-legally, I'm not sure. That's one of my challenges. If anybody wants to comment, or any suggestions, how do they deal with some of these scenarios?
You're saying that you weren't sure if you did the right thing, because I think you did exactly the right thing.
Yeah.
Am I muted? No.
No.
I am. Yeah. So for those people who've got mental health issues, it really has to be addressed in order to facilitate their competency. So you know, and this whole concept of competency, as we know, it's a fragile thing, particularly in those patients who have got mental health issues or reduced capacity for one reason or another. And indeed, adolescents can have competency to make some decisions, but not others. So it's all about a journey, Purnima, towards trying to get to a place where that person is feeling like they can, you know, be adequately supported, got the information they need to make a decision. And so involving the psychiatrist, while it, well, fortunately she had a psychiatrist, sometimes you have to actually find somebody to make that decision with you, but it's all due diligence.
Yeah.
The thing about medical abortion, I think, is that sometimes we could maybe get a bit pressurized by the time. You know, if she presented to you at 8 weeks and 4 days, what would you do?
Yes,
You know?
yeah.
You would look after her mental health, and then that would change the mode of abortion care she would have to have, you know?
Yeah.
Yeah, so it's got to be front and central. I think it's quite right, yeah. And you've obviously got a good empathy with making those kinds of assessments, but it's important to remember that sometimes young people also come with a whole lot of other people, including us as health professionals, deciding what we think would be in their best interests. And sometimes they don't want to do what we think would be the best. Because I worked for many years at the Children's Hospital and was often involved in consent issues with adolescents. And one of the things we used to say was that we always agreed that the patient was competent if she agreed with the treatment we were offering. And if she disagreed, then we questioned her competency. You know, so it's important to sort of remember that as well, that, you know, it's about allowing people to have the space. And sometimes I know I've got the luck and they have been able to say, look, come back next week and I'll do it for you. Not necessarily a medical abortion, but, you know, you'll have time. So I know that it's harder when you're trying to get things done in time, but you can't rush this, can you? Anybody else want to comment on it? Ling? I just wondered if Ling or Louise or Catherine, anything to add, or Yvonne?
Hi, Ange and Sam have got something to say, but we've just had the phone on as well because we've had trouble with the sound. So just give
that'd
us
be
a
great
moment.
to hear.
Okay, thanks. Go, Ange.
I just wanted to say, add to what you said, Patty and Ponema. I think you did an amazing job. And I would add to that, that as long as young people are really well supported, and sometimes that's tricky to find out who's supporting them and who their connections are. But I think when mental health comes into play as well, that it's just that extra working out who they have as support, who else they're talking to in their decision making and talking through information with. And that, yeah, they might make a decision that we think might be the wrong decision for them, but in the end it's not our decision to make. So as long as they're well supported and have good supports in place, then and that is part of our job, which can make it more complex at times. But I think, yeah, young people will make decisions and can, even with mental health issues, as long as they're got good supports in place. If they don't have a psychiatrist, that we support them to connect into good supports is also a thing that we can do, which makes it sometimes longer to work with them and harder to work with them, but it's also important that we do that.
And sorry.
Yeah, I also agree that, yep, you totally did the right thing. I think it's something that, yeah, I guess it depends on timelines as well. Sometimes there is that pressure of the timeline, and as Ange said, as long as you've got someone in support of that person and that they've made the decision themselves, generally they come in with an idea of what they want and supporting them through that. Yeah, I had a complex one recently that she's currently homeless and she's got a 1-year-old, and but she hasn't turned up to her next appointment, and I guess just, yeah, it'll come back and just working through that and what we can do to support her, because she'll be over the 12 weeks by the end of this week, and we don't have capacity to see her. So just all of those things. And I guess, and that's where we bring in, like, I spoke to 1-800 My Options today just to get, yeah, what options are going to be on the table, costs involved, because there'll be travel because we're rural. So there's a whole lot of things that you have to take into account. Yeah. Yeah, and it does take extra time. But yeah, with young people, I guess they can come back as many times as they like, and as long as we're giving them information about timelines, so that they've got options, or what their options will be as time goes along as well.
Are we muted?
Not yet.
Thank you.
Can I also mention a case I saw recently? And so it was not a mental health case, but similar. It was a lady I think in her late 30s or even early 40s with intellectual disability. But so it was a new patient, and it was referred by another GP to us. And on the initial presentation, she presented with her mom, and her mom was kind of the bossy kind of mom, and was telling her and telling our staff that this patient should not have this baby because she will not be able to look after the baby. And the patient looks, she was definitely has intellectual disability. But during the consultation, Lauren, our sexual clinic nurse, realized the patient understand a lot of the consultation and might be able to make decision for herself. So we contacted the regular GP, and eventually we got the information that the patient was actually making her own medical decision. We thought the mother was the guardian, or the mother was the one who's making decision for her. But actually in her case, the patient herself was making decision. So I think it can be tricky sometimes. Our initial impression who's making the decision, who's not able to make the decision. In this kind of case, we really need to confirm, have a clear documentation information before we go ahead with the decision.
Yes, that's right. Because patients with intellectual disability, it's a little bit trickier, isn't it? Because I was reading the article, if we need to, they need some kind of a guardianship or something. We need to apply for a guardianship if you're not sure about, if you're certain that they have intellectual disability, and if they can't make decisions, we need to apply for a guardianship. But in this patient, she definitely was able to make decisions for herself.
Just mention it. Yeah, it's the category that we need to be aware of is special medical procedure. So for patients who are deemed not competent, and that actually includes a minor that you feel isn't competent to make their own decisions. And I guess the thing I was going to add, Purnima, is that most of the time I decide that the young person who comes requesting an abortion is a competent minor. But recently we had a patient who was not competent at age 15 to make a decision because of her psychiatric state, actually. So when you have either a minor who's not able to make the decision, their parents can't make it for them. And in the case of those with intellectual disability, for special medical procedures, you do have to go through VCAT. And the special medical procedure is a non-reversible procedure. So just for people's interests, it includes sterilization and abortion, obviously. It includes hysterectomy because it's irreversible, but it also includes donation of an organ. And it includes enrollment in medical trials. So all of those things have to be taken away from the person who would be normally the guardian. That doesn't mean that they are allowed to make the medical decisions if it's a special medical procedure. And laying that out for a young person or a person with medical an intellectual challenge with the person who's brought them or support people, just laying that out there can be quite a relief in itself if you explain that it's to make sure that there's an advocate that's completely neutral for the young person. And just so that you're aware, because the first thing that I always worried about in these situations was, but how long is that going to take? You know, courts take so long. Well, VCAT can meet for an emergency situation, and we have asked them to do this on many occasions now. They can meet within 48 hours and give us an opinion so that we can go ahead with the procedure. And they have a really good web-based information service and a hotline, and they're very responsive. Yeah, it's a good resource, yeah.